once C is taken care of, then we have to take care of the D. What D stands for? D stands for disability. Now, what disability are you talking about? Talus equinovarus, cubitus varus, cubitus valgus, cleft lip, cleft palate. Then we are talking about a neurological disability. So we are talking about a neurological disability here. And in disability part of this primary survey, we have to so in this disability, we have to look for a neurological disability. And in this neurological disability, we have to see three things. What are those three things? Checked in exam. GCS. What is GCS? Scale. Glasgow Coma Scale. Then we should also look for pupillary signs. And then we should also look for lateralizing signs. Now, what is this lateralizing sign? What is the GCS? We will come to know when we talk about head injury, right? But at this point, we just need to know that in D part of our primary survey, we have to see three things. We have to see three things, that is GCS, pupillary signs, and lateralizing signs. Now, then comes E. E stands for environmental exposure. E stands for environmental exposure. We just have to look at these three things in the D part. And what are these three things? We'll come to know in head injury. Okay. Now, environmental exposure. Now, this A, B, C, this E is not mentioned here just to complete the rhyme. A, B, C, D, E. E is entered here, or E is here to emphasize on the fact that a patient of trauma needs to be completely exposed, because the patient of trauma can have injury at back also. So you have to see the back of the patient. So you have to expose the patient of trauma completely. And it is also being mentioned here that since trauma patients have a very high tendency of going into hypothermia, after exposing these patients, we should cover them with warm blankets. And because patient of trauma has a very high tendency of going into hypothermia, the guideline recommends that we should give fluid to a patient of trauma at a 39 degrees Celsius. So whatever fluid you are giving to a patient of trauma should be given at a temperature of 39 degrees Celsius to avoid hypothermia. You can ask. So you should tell him that ask her, don't ask me. Why are you disturbing me? No, you tell him. Okay? So why didn't you answer him? Okay, this is joking. Okay, anyways, so we have to be fluid at a 39 degrees Celsius. That's it. Okay, and another important point here is that since the patient can have an injury on the back, right? And you have just seen that a patient of trauma, we need to be very careful about the spine. A patient of trauma, we need to be very careful about the spine. So when we have to see the back of the patient, we have to be very careful about the spine there also. So in turning the patient to see the back, you should turn the patient of trauma as if you are turning a log of wood, so that the spine doesn't get disturbed. And this turning of the patient like a log of wood is called log rolling. This turning of the patient is called log rolling, right? And this is a very commonly asked question in exam, that how many individuals are needed to do this log rolling. Very commonly asked question, and there is a lot of confusion. There is a lot of confusion on this. It is 3 plus 1, that is 4. But please be very careful in this. If they ask you how many individuals are required for log rolling in patient with lower limb fracture, with a patient with lower limb fracture, it is 5. Otherwise, minimum 4. Otherwise, minimum 4. Okay. 3 plus 1 is 4. No, 3 plus 1 is the number of individuals. 3 individuals will turn and 1 individual will examine. 3 individuals are going to turn and the 1 individual will examine. So it is 3 plus 1. बिना ब्लड लॉस के भी हाइपोथर्मिया हो सकता है फ्रोजन ओके हो सकता है फ्रोजन वाटर में गिर गया तो ड्राउनिंग होगी, वो भी ट्रॉमा है, बट ट्रॉमा में ज्यादातर टाइम क्या होता है, ब्लड लॉस होता है। रोज रोज थोड़ी फ्रोजन वाटर में गिर रहे होते हैं, गिर सकते हैं पर ज्यादातर टाइम तो ट्रॉमा में ब्लड लॉस होता है। तो हाइपोथर्मिया का रीजन प्राइमरली वो होता है, और भी हो सकता है ना। चले आगे 10. So this is how we conduct our primary survey, and then what are the things which are going to help us out in primary survey? We should know 2 important things at least. No other detail required. Just 2 things are very important. Now, as an adjunct to primary survey, there are 2 X-rays. There are many things which are helping, but these 2 things are very important. 2 X-rays, and now we have FAST, which is there as an adjunct to primary survey. What are the 2 X-rays?
Chest and the pelvic.
Very good. 2 X-rays are chest X-ray and a pelvic X-ray. And very, very important point in this is, very, very important point, and highlight that in your notes. These X-rays which we are going to do are always going to be AP views, never PA view. It is always anterior-posterior view. Okay. And what is FAST? Focused assessment sonography in trauma. Focused assessment sonography in trauma. Right? So these are the 2 important. There are other things also not required. They will not check you on that. They will be checking mainly on this, that what are the 2 X-rays required in primary survey. So you should know chest X-ray and these X-rays are always AP views. Now, this was about our primary survey, and then another important thing. You all have seen, and you have already told me that also, that the most important thing in any patient of trauma in C part is control of the bleeding. This is what you told me. There are 2 things important. One is a control of the bleeding, and second is the replacement of Blood. These are the two things. Out of these two things, control of the bleeding is the most important thing. You already have told me, right? Now, what will happen if we fail to control the bleeding? What is going to happen if we fail to control a bleeding in a patient of trauma? Patient will go into shock. So let it be. You keep on giving fluid. Patient, can you take care of the shock with the fluid going on? Can you take care of the shock with the fluid going on alone? No. So what will happen? The patient of trauma, if you keep on giving fluid and you don't bother to control bleeding, the patient will go into a triad of death. Patient goes into a triad of death. Patient goes into a triad of death. So they can ask you a question, what constitutes a triad of death in trauma? The triad of death is constituted by acidosis. Triad of death is constituted by acidosis, hypothermia, and coagulopathy. Now, this is what I'm going to talk about is a very important and a latest concept in management of a patient of trauma. And please try to understand this concept. Now, can anyone tell me that what are the ways? Imagine there is a bleeding happening from a vessel. Imagine there is a bleeding happening from a vessel. What are the ways to control bleeding from this vessel? Pressure. One. You can apply pressure. Pressure. Tourniquet is also again so one pressure. Pressure tourniquet से लग सकता है, हाथ से लग सकता है, कैसे भी लग सकता है. Pressure. One is pressure. And you can apply. You can ligate the vessel also. You can ligate the vessel also. And imagine this is a vessel, and this vessel has an injury like this, and it is pouring blood. Okay, what else? Very good. So pressure here, wo bhi. So we have three ways: pressure, ligation, and also applying a ligature. Repairing the vessel. Pressure, ligature, and repair of vessel. Agree? If you repair a vessel, if the injured vessel is repaired, then also the bleeding from a vessel will stop. Now tell me now, out of these three ways, which is going to take a longer time? Simple. Repair. Now this understanding is the key here. Because this is a new realization by surgeons. That surgery is kind of another trauma to the body. Body doesn't know that you are doing surgery to help body. For body, surgery is another trauma. We are giving this trauma to the body to help body though, but then surgery is now understood that it's another type of trauma to the body. Right? Now, if we prolong the duration of surgery, you can appreciate the duration of trauma is going to get prolonged. Agree? So, with this understanding, let's build a concept. Imagine there is some fight across between the two coaching institutes. And one of them stabbed the other one at a groin. Right? And there's a femoral artery injury. There's a femoral artery injury just across the road. This happened, and you are all here sitting and trained in trauma, waiting for such fights. Right? Just across this happened. So what will happen? The patient will come immediately. Right? So patient will come immediately. So what will you do? You will do ABC, pressure, and apply, repair the vessel. Because this patient has come so early to you. Please understand, since this patient has come so early to you, it is quite likely that this patient will be in hypertension, but might have not developed a triad death because the patient has come so early, right? So this patient, since has come so early to me, there is a femoral artery injury. So I can think of giving a trauma of surgery in prolonged way by doing a repair of this vessel, because the patient himself is not in a very severe state of trauma, right? But imagine the same fight happened at a your examination center, examination, and there they now here in a trauma center. Now by that time this patient will reach here, you can appreciate this patient not only will be in hypotension, may also have developed acidosis, hypothermia, and coagulation. Now, since this patient has come so late to you, and the triad of death has already set in, so if I prolong the duration of surgery by trying to do a repair of this vessel, I will do a very beautiful repair, but on a dead patient. Because of the surgery, this patient can die, because surgery is another stress, another trauma. The patient is already in a severe stressful condition. If I prolong the duration of one more stress of this surgery, I may end up having a dead patient. So what the latest guidelines says in such kind of scenarios, they say that our primary objective is living problem is better than a dead solution. So in such a kind of scenario, we should do the damage control. We should not try to do heroics in a patient who is already dying. So we should try to do a damage control first, and if at all that damage control helps the patient, then only we should try to do something heroic later. So what does that mean? Imagine this patient has come to me now from Noida. It took so long for him. Last time in traffic, all that. When he reached here, patient is not only in hypertension, but already has developed hypotension, hypothermia, and coagulopathy. So in this patient, I'll follow the same principle A, B, C. In C, I'll apply a pressure, and after applying a pressure, I will not do a repair of this vessel. Rather, I'll ligate this. Ligate this vessel. I will ligate this vessel. Now, once I have ligated this vessel, I have taken a minimum time to control this bleeding. I have plugged that hole. I have plugged that hole which was there in the bucket. Right? That hole got plugged. What way I have plugged it, that's a different thing, but I have plugged it. Now what I'll do, I'll send this patient to ICU. Now what I'll do, I'll send this patient to ICU and resuscitate this patient now with blood products, vasopressor and all. And with ICU care, it is quite possible that this patient now may recover from this acidosis, hypothermia and coagulopathy. Or it is also possible with this ICU care also the patient may not recover at all, because this patient is already in such a severe state that even when I have taken a minimum time, the patient succumbs to the injury. So in this case, what I'll do, this is the minimum I could have done, this is the maximum I could have done. If in this patient I would have tried to do a repair, this patient would have died on table rather than reaching the ICU. This patient could reach ICU just because I have taken a minimum time in this surgery. But what if there can be scenario that in ICU this patient can improve also, and once this patient will improve in ICU, I will bring this patient back to the operating room. I will bring this patient back to the operating room and try to see that if at all I can salvage this limb or not. If the limb is already gangrenous, you have ligated a femoral artery, the limb may be gangrenous. So if the limb is gangrenous, I will chop this limb off. I'll do amputation. But what I'll achieve, what I have achieved a life, though without a limb. So this is something called damage control surgery. This is something called damage control surgery. What does that damage control surgery means? It means that don't try to do a long duration surgery in a patient who is already in a very severe state of stress. That is hypotension, hypothermia, coagulopathy, and acidosis. If all four are there in any given patient, in such patient, don't try to prolong the duration of first surgery. The first surgery should be the minimum duration surgery, right? So this damage control surgery has three components, three phases: DCS1, DCS2, and DCS3. DCS1, DCS2, and DCS3. DCS1 is control of bleeding or infection in a minimum possible time. Control of bleeding or infection in a minimum possible time. Then DCS2 is ICU resuscitation. And after ICU resuscitation, it depends. If the patient improves, then DCS3 will come into play, and that will be a definitive treatment. So that, what does that damage control surgery concept says? That don't try to do a definitive treatment on first surgery in such patients. Rather, do a minimum and later on do a definitive treatment. This is what this type of procedure when we do, where we don't do a definitive thing on a first surgery in a trauma, is called damage control surgery. We are trying to control the damage which has already happened. This is called damage control surgery. And the most common complication of damage control surgery is wound infection. Most common complication of a damage control surgery is wound infection. So this is something called damage control surgery, and you should know what that damage control surgery concept is. Any doubt? What is ICU resuscitation? You will send this patient to ICU and there you will resuscitate now. No, you have already ligated a problem. You have already controlled the bleeding. Now give him fluid, blood and blood products. You may need to give vasopressors also. Speed is fine? Please everyone. So please, अगर speed कहीं पे भी बढ़ती है बीच में रोक देना मुझे, right? Then comes, so this was about a damage control surgery. Now then comes head injury. क्या हुआ? समझने का ज्यादा है. It is more of a understanding. देखो trauma questions ना is all about concept. Trauma question रटने से नहीं होगा. Trauma question रटने से नहीं होते. If there is a direct question, if they ask you what is a DCS, what phase is ICU resuscitation phase in DCS, you can easily say that's a phase 2. It's a direct question. But in exam now, we are not getting those direct questions. We have to have the understanding of the concept, right? Now, let us talk about head injury. Now, first of all, can you tell me how does a patient of head injury presents? What will be the presentation? How will you know in a given clinical profile of the patient? You are told patient has a RTA. You are told patient has a road traffic accident. And in that road traffic accident, how will you figure out that this patient has a head injury? Now, so every unconscious patient has a head injury? Very good. So we should understand, first of all, in a given clinical profile, that this patient has a head injury. So how will we identify that the patient has a head injury? The patient will have loss of consciousness or altered sensorial. Patient will have loss of consciousness or altered sensorial. Patient will have vomiting. Patient will have vomiting. Patient will have seizures. And patient will have ear, nose, or throat bleeding or discharge. These are the cardinal symptoms of head injury. These are the cardinal symptoms of head injury. If these are there, you can presume that the patient has a head injury. Okay, now can anyone tell me that why are these things happening? What is the reason of these things in a head injury? Why the patient is vomited? Why the patient is developing seizures? Why the patient is having a... So the major reason of all these symptoms of a patient of head injury is raised intracranial pressure, and because of a raised intracranial pressure, patient is coming to us with these symptoms. Now, can anyone tell me, on the basis of these symptoms, think about it and then answer, okay? Can you tell me, on the basis of these symptoms, can we make out what type of head injury this patient has inside? Whether the patient has EDH or SAH or SDH, can we make out? No. These are the symptoms of increased intracranial pressure. Whatever type of head injury there inside will lead to these kind of symptoms. So that means, on the basis of symptoms, we can't make out the type of head injury. Simple. Now, there are certain signs also of head injury. There are certain signs of head injury also. What are the signs of head injury? One. The signs of head injury are raccoons or black eye sign or panda sign. There can be raccoon eye sign. There can be a black eye sign. These are all same. What is this sign? Blackish discoloration around orbit. Blackish discoloration around orbit with subconjunctival hemorrhage. Blackish discoloration around orbit with subconjunctival hemorrhage. Now, very important point to note in this is, this sign can be there due to local injury to the orbit also. If somebody punches you on orbit, you will get this sign again. But then this can also be a sign of anterior, a very commonly asked question, anterior cranial fossa injury. This can be there in a patient of anterior cranial fossa injury. Then there can also be another sign called Battle sign. What is Battle sign? Bruises bluish discoloration around mastoid. Bluish discoloration around mastoid. Bluish discoloration around mastoid. It can also be associated with hemotympanum or CSF photoria or rhinorrhea. And this sign is there, very commonly asked question, in a middle cranial fossa injury. This will be there in a middle cranial fossa injury. So, hemotympanum with CSF photoria or CSF rhinorrhea, this will be there in a middle cranial fossa injury, right? Now, very important point. So what we can again infer from here, that on the basis of symptoms and sign in any given patient, we just cannot make out the type of head injury, but we can to a certain extent make out the site of injury. The only thing we can make out, that too, if these signs are there, sometimes the site of injury in the head, but we cannot make out the type of injury. So to make out what is the type of injury, we have to do some investigation. So what is the investigation of choice? The investigation of choice for a head injury is non-contrast CT. Investigation of choice for head injury is non-contrast CT. Okay, now in non-contrast CT of a patient, please note this point, and we'll be talking about this injury separately also. In SDH and in EDH. What is SDH? Subdural hematoma. EDH is extradural hematoma or epidural hematoma. Extradural hematoma or epidural hematoma, right? In SDH, in non-contrast CT, in SDH, in non-contrast CT of a patient, you will get concavo. रेडियो हो गया? कोई बैच, कितने बैच है? 3 बैच है? Okay, anyways, concavo convex, मटर पनीर पे कॉन्सेंट्रेट करो. Concavo convex or concavo convex or crescent shaped opacity. Concavo convex or crescent shaped opacity. In EDH, you will get biconvex. In EDH, you will get a biconvex or lenticular shaped opacity. Biconvex or a lenticular shaped opacity. Okay. Now, whenever a patient of head injury comes to us, you can appreciate that you have to do non-contrast CT to find out what type of injury inside. Got it? Now, not only you have to do a non-contrast CT, you also are supposed to grade the injury in head. How will we grade the injury in head. What is the grading of head injury? Yes, grading of head injury will happen. It is called mild head injury. It is called moderate head injury. It is called severe head injury. What is mild, what is moderate, and what is severe? Can anybody tell me? Mild is when the GCS of the patient is between 13 to 15, it is mild. If the GCS of the patient is 9 to 12, it is moderate. Glasgow coma scale. Picture अभी बाकी है, don't worry. GCS 13 to 15, moderate, GCS 9 to 12. If it is less than or equal to 8, it is severe. 8 or less than 8 GCS is called severe head injury, and you should also know 8 or less than 8 GCS is also a definition of coma. अभी देखेंगे वो हम इमेजेस में बात करेंगे, डोंट वरी, दिखेगा, सब दिखेगा, वो समझाया भी जाएगा, डोंट वरी, राइट? 8 or less than 8 GCS is a definition of coma. So that means we have to assess the GCS of the patient to assess the grade of head injury. We have to assess GCS of the patient. We have to assess the GCS of the patient to know the grade of head injury. And GCS is Glasgow Coma Scale. Now, how will we assess GCS? Glasgow Coma Scale. GCS is assessed by 3 things. ये क्वेश्चन भी एग्जाम में पक्का है. One question on GCS comes regularly in exam. So आप बिना GCS को जाने you can't appear in this exam. As simple as that, right? So in GCS we have a eye response, we have a verbal response, we have a motor response. In GCS we have a eye response, we have a verbal response, and we have a motor response. In eye response, if the patient opens his eyes spontaneously, if the patient opens his eyes on his own, the score given for this will be 4. If the patient opens his eyes to sound, तो बर्तन गिरा तो आंख खुल गई, साउंड आराम से ले, आंख बंद थी, बर्तन साइड में गिरा, it is 3 means to sound. I just gave you example of बर्तन, but जब तुमने बात करने की कोशिश की तो तुमने साउंड की तो उसने आंख खोल दी, right? To pressure. When you applied pressure on the sternum, the patient then opened eyes, was not opening eyes on sound, but when you applied some pressure, patient opened his eyes. Score given will be 2. And when the patient is not opening his eyes at all, score given will be 1. You try to make a sound, you try to put a pressure, patient is not opening eyes. Is not opening eyes. It is 1. In verbal, if the patient is oriented, आपने पूछा कहाँ हो, उसने बोला मैं हॉस्पिटल में हूँ और ये हॉस्पिटल है. It is 5. Patient is confused. You ask patient, where are you? He said, I am in a movie hall. He is confused. 4. Right? And you ask this patient, this to a patient in the hospital mind. Okay? Because you can ask this patient, he's in movie hall also, and if he says he's in movie hall also, he's right. Huh? Mind it. Okay. So confused. 4. Now, if the patient is talking to you in words only, who is not word. Patient is just making words. Can talk only in words. It is 3. Patient is making only sounds. You are trying to talk to the patient. Patient is just making sounds. It is 2. And if the patient is not even making a sound, it will be wrong. Right? In motor, if the patient obeys command, आपने बोला, please raise your hand. Patient has raised his hand. Score will be 6. Localizing, it will be 5. What do you mean by localizing? Imagine I am applying a pressure here. I am applying a pressure to the patient here. Patient brings his hand and try to localize his pain here. Right? So it is localizing. So score will be 5. If the patient is doing a flexion withdrawal to pain, which is also called normal flexion. What is flexion withdrawal to pain? आप यहाँ pressure लगा रहे हैं, you are applying pressure here, and patient is trying to, he is not able to reach here. Localizing means reaching here. In withdrawal to pain means he is trying to take your hand off from here, but he is not being able to reach here. He is attempting to remove this like this. Are you understanding? You are applying a pressure to the patient here. One patient reaches his hand here and removes your hand from there. Reaches here and removes your hand from there. It is localizing. Another patient, you are applying a pressure, patient is raising hand and doing this. He is doing a flexion withdrawal to pain, but he could not localize. वो कोशिश कर रहा है कि कहीं pressure लग रहा है, उसे पता लग रहा है कहीं there is some pressure being exerted on him, and he is trying to get rid of that pressure, but he doesn't know where that pressure is being exerted. Okay, तो ये समझना बहुत important है, सिर्फ रटने से नहीं होता, क्योंकि GCS आपको कैलकुलेट करना होगा. GCS पे क्वेश्चन in your casualty when you work as an intern, you will be asked to calculate the GCS also, that time also. That is why GCS is important. Then abnormal flexion, which is also called decorticate. What is decorticate? Abnormal flexion. Decorticate is abnormal flexion. What abnormal flexion actually means? You are इतना भी नहीं, यहाँ पे प्रेशर लगाया आपने and patient is doing this. Patient do करने को रहा है, मतलब he knows that there is some problem in the form of pressure is happening somewhere and he is trying to do this. जहाँ ये भी नहीं कर पा रहा, just doing this. This is called decorticate or abnormal flexion. नहीं तो कर देता. Abnormal extension, decerebrate. What is decerebrate? This is decerebrate. You are applying a pressure, patient is doing this. Instead of doing this, he is doing this. This is decerebrate. Okay, and patient is not at all doing anything. Is one. Patient is not doing anything is 1. Okay, and now, very, very important. Imagine the patient is having a tube inside the trachea. Patient's GCS was less than 8, we know that we have to put in a tube. Patient who has oxygen saturation with oxygen less than 85%, you know you have to put in a tube. And this patient has a tube inside the vocal cord. Now, how will you calculate V of this patient? You are not going to play dumb charades. So, how will you calculate V of this patient? Huh? we will write non-testable. We will write here non-testable. Means patient has a tube inside the trachea, we can't test it. Right? Don't tell us to test because it is non-testable. Okay. And say for example, patient is having eyes swollen. Swelling ke karan, because of the swelling, the eyes are closed. Now, how will you assess eye response here again? You can't assess. So you will again write non-testable. And imagine patient is given a neuromuscular blocker. Patient is already paralyzed. If the patient muscles are paralyzed, there will not be any motor response. So that also, then also we will write non-testable. Then also we will write non-testable. Then also we'll write non-testable. So whenever we cannot assess any response, for that we will use NT. That is non-testable. So say for example, eye response of the patient is 3. What do you mean by 3?
Sound.
Opening to the sound. Patient motor response is 5. Motor, localizing. And patient has a tube inside the trachea. We will write. So the GCS of this patient will be written like this: E3, VNT, M5. But what were we doing earlier? Let me tell you. You should know what were we doing earlier also. This is the latest thing. Okay, what were we doing earlier? Imagine the eye response of the patient is 3. Okay, imagine the eye response of the patient is 3 and motor response of the patient is 5. And the patient has a tube inside the trachea. The same scenario. What were we doing earlier? We were writing V like this and writing T like this. That the patient has a tube inside the trachea like this. And to calculate the total GCS of this patient, what were we doing? 3 plus 5. We were taking 1 arbitrarily for the verbal response and writing T as a suffix. So total GCS of this patient will be 90. So what does this 90 means? It suggests that patient has a tube inside the trachea because you have write T as a suffix and you have arbitrarily taken 1 for the verbal response. So this we were doing earlier. Now we are not doing this. We are just writing it like this. Okay? Okay? Okay. So this is how we calculate GCS of the patient. हाँ? अब यहाँ पे अब ओके इसका रिजल्ट क्या है? इसमें हम बोलेंगे patient GCS is 8 and patient has a tube inside the trachea, because of which we could not assess the verbal response. So you have to mention for what reason you could not assess the particular response, and you have to sum up the other 2 responses. We can't. Now, then comes question में बताया होगा. Question में you will be told that the patient is opening eyes to the sound. Patient who is in ICU, intubated, opening eyes to the sound, and he is localizing pressure. What is the GCS of the patient? It is E3, VNT, M5. ठीक है? एट और लेस देन 8, उसमें उसमें नहीं कर सकते, नॉट इन दैट सिनेरियो, जहां पे तीनों कैलकुलेट हो रहे हैं उसी में. Then comes what is the most common head injury. We should know few important points of the important head injuries. What is the most common head injury? Most common head injury is contusion, followed by STH. Most common head injury is contusion, followed by STH. Let us first talk about STH. Subdural hematoma. Subdural hematoma. Now, this subdural hematoma is due to injury to bridging veins and dural sinuses. SDH is due to injury to the bridging veins or dural sinuses, right? And this SDH can be an acute SDH, can be an chronic SDH. It is called acute SDH. It is called acute SDH when it is seen within 3 days of trauma. It is called chronic SDH when it is seen more than 21 days after trauma. And very, very important point to note in this is chronic SDH is commonly seen in elderlies. Chronic SDH is commonly seen in elderly. And please, this is a very commonly asked thing in exam also. If this is a profile of the patient provided, you are told an elderly patient comes to you with sudden onset headache or loss of consciousness, even when no history of trauma is mentioned. Even when no history of trauma is mentioned, your first diagnosis in this scenario should be chronic SDH. An elderly patient comes to you with a sudden onset headache or loss of consciousness, even when the history of trauma is not there, your first diagnosis should be chronic SDH. But please be very careful about further another question. If you are asked and a patient comes to you with a sudden onset, severe headache or worst headache of his life or thunderclap headache, the first thing that should come to your mind is subarachnoid hemorrhage. The first thing that should come in your mind should be subarachnoid hemorrhage. Thunderclap headache, worst headache, or severe headache. Headache or loss of consciousness? Headache or loss of consciousness? What if it is? You will not be checked on that. Okay. They will ask you straightforward. Okay. Now, SDH, important point for us to know. SDH is more common in boxers. SDH is more common in boxers, and SDH as a head injury is more severe than EDH. SDH is more severe head injury than a EDH. You should know these points. Then comes EDH, which is also called extradural or epidural or extra axial hematoma. This EDH is due to injury to middle meningeal artery. It is due to injury to middle meningeal artery, and most common site of this most common site is temporoparietal region. Most common site. Now, by now, all of you must have got the hang of understanding my handwriting, the calligraphy. अच्छा, मेरा अच्छा है, मेरे से अच्छी भी है, मेरे से खराब भी है किसी की. Temporoparietal region. And very important. Now, can anybody tell me? Can you tell me how will a patient of EDH going to present to you? EDH is going to present to you with the same signs and symptoms which any other patient of head injury has. Loss of consciousness or altered sensorium, vomiting, seizures, or ear, nose, or throat, bleeding or discharge. But ये कब से हाइपरटेंशन अभी करेंगे इसका. We will talk about that. EDH patient can also present to us. Important point to notice. EDH is one head injury which can also present to us with something called lucid interval. What is lucid interval? Loss of consciousness first, regaining consciousness, and again going into loss of consciousness. So, loss of consciousness, regaining consciousness, and then again going into loss of consciousness. This period of regaining consciousness between two episodes of LOCs is called lucid interval. So, if lucid interval told, you should think of EDH. You should think of EDH. And one more important thing, in EDH, you can also get a lateralizing sign. Now, if you can recall, I told you that we are supposed to see three things in D in primary survey. GCS, pupillary reaction, and lateralizing sign. So what is this lateralizing sign? And once it is there, what to do? We have to understand what is lateralizing sign. And once it is there, what are we supposed to do? We should understand. Lateralizing sign is, in lateralizing sign, you will find a patient coming to you with head injury, having one side pupil dilated, having one side pupil dilated with opposite side body weakness. A patient will come to you when there is a lateralizing sign. Patient will come to you with a pupil dilated on one side and the weakness of the body of the opposite side. If any patient comes to you with this kind of a sign, first of all, this is called lateralizing sign. First of all, it is called lateralizing sign. And this is a telltale sign. This is a sign which is a confirmatory that this patient has a EDH on the side of pupillary dilatation. So this is a sign which tells us with clinical examination itself that this patient has a EDH on the side of pupillary dilatation. And this is called ipsilateral pupillary dilatation with contralateral hemiparesis. Paresis or plegia. Right? So if any patient comes to you with one side pupil dilated and opposite side body weakness, it means it's a lateralizing sign. And once it is there, please note it in capital letters. Once this is there, we just don't need to do even non-contrast CT. Investigation of choice or head injury we have written is non-contrast CT, but we will not do here non-contrast CT. We will directly take this patient to the operating room and evacuate this EDH by giving burr hole. For evacuating EDH, we do burr hole. We make a hole in the cranium. Burr hole. And where are we going to do burr hole? On the side of pupillary dilatation, just above pterion. Just above pterion. Just above pterion. And for this burr hole, you don't need to be a neurosurgeon. Even if you are a general surgeon, you should know these life-saving procedures. The way to evacuate EDH is through making a hole in the cranium, which is called burr hole. ठीक है? Now, sweet ठीक है? Sweet is fine. Once there is an EDH, once there is a lateralizing sign, even when you are not a neurosurgeon, even when you are a general surgeon, you have to evacuate this hematoma by giving a burr hole on the side of pupillary dilatation just above pterion. Just check it out. पूरी बात चलें आगे. right? Then comes SH, subarachnoid hemorrhage. Subarachnoid hemorrhage. You should know there is a lot of confusion on this. The most common cause of SH is trauma. Most common cause of SH is trauma. But please be very careful. If you are asked what is the most common cause of spontaneous SH, please be very careful. If you are asked what is the most common cause of spontaneous SH, it is rupture of Barry's aneurysm. It is rupture of Barry's aneurysm. We don't need to go into further detail in SH, not required. Then comes, there is something called diffuse axonal injury. There is something called diffuse axonal injury. Diffuse axonal injury is a worst head injury. Diffuse axonal injury is the worst head injury. A question asked, which of the following head injury is the worst head injury? Sir, diffuse. And this is something very, very important for you to know. Diffuse axonal injury is one head injury out of so many head injuries where non-contrast CT can be normal. So it doesn't mean that if a non-contrast CT in any patient of head injury is normal, he doesn't have a head injury. So in a patient of head injury, non-contrast CT can be normal also. And when will it be normal? In this head injury. Only in this. Only in this head injury, the non-contrast CT will be normal. And that is the reason why investigation of choice for that this head injury is MRI. Right? So investigation of choice for this head injury is MRI. Right? Then you should also know something about scalp laceration. Yeah? We will see in what happens in diffuse axonal injury. This diffuse axonal injury, since you have asked it, not required though, but since you have asked it, diffuse axonal injury happens because of a shearing tear between white and gray matter. So in MRI, you can see the differentiation of a white and gray matter here. Right? So this is what you see, differentiation. Yes. Right? So this is what you get to see, not required at grade level. You just need to know that non-contrast CT can be normal and investigation of choice here is MRI. They will not give you MRI and ask you that, find out. And they will not ask you that what finding you will get in MRI also. Don't worry. Now, then comes scalp laceration. Scalp is a very vascular layer. And once it bleeds like hell. Once scalp laceration bleeds, it bleeds like hell. So there is a very important scenario which as an intern you will be facing also. You will be asked to suture a scalp laceration and you will find it so difficult to suture a scalp laceration because it bleeds like hell. So what to do when a scalp laceration is bleeding? So there was a question asked, what is the best way? What is the best way to control bleeding from scalp laceration? The best way to control bleeding from scalp laceration is by suturing. Best way to control bleeding from a scalp laceration is by suturing. But then you can, I just told you that suturing you will find it difficult to do. So if suturing is not there in your choice, then to do the suturing, what we do, we apply a artery forceps. Scalp has 5 layers. You know that?
Yes.
What are those layers? ALP. What is ALP? Glea aponeurotica. Aponeurotica layer, loose areolar tissue, and periosteum. Right? So what we do, we hold the aponeurotica layer, a glea aponeurotica layer, and evert it. Glea aponeurotica we hold with artery forceps and we evert it. So eversion of glea aponeurotica controls the bleeding. So when you are an intern and if your co-intern is struggling to suture a scalp laceration, go in style, take an artery forceps, hold the glea aponeurotica and evert it and then take. Now do. Your co-intern will be very impressed, and if that co-intern is a girl, okay, now. Okay. So eversion of glea aponeurotica, and then we should know. Obviously, you should know where is glea aponeurotica. And if by any chance you try to do that and you could not find a glea aponeurotica, she will say, "Kahan se aa gayi?" So don't try heroics when you don't know how to do that. Okay? So don't try to impress when you know you can't do that. Okay? So this is how we control bleeding. Now comes the management. Now comes the management of a head injury. Now comes the management of a patient of head injury. Now, she has been saying for so long, hypertension, hypertension, hypertension. So, she should not feel left out. So, what is this hypertension issue? Listen to this very carefully. It's a very important point too. In every patient of head injury, listen to this very carefully. In any patient of head injury, you all must have read it in your physiology classes also. In every patient of head injury, there is a reflex called Cushing's reflex. What is that Cushing reflex? Hypertension and bradycardia. So any patient of head injury, once there is head injury, there will be hypertension and bradycardia. Right? But if any patient of head injury, so any patient of head injury, if there will be hypertension and there will be bradycardia also. But if any patient of head injury has a hypotension, if in any given question you have a profile of the patient suggesting a head injury and there is hypotension provided in the parameter of the patient, you should always think of bleeding happening somewhere else. Because a patient of head injury cannot be in hypotension initially. So if a patient of head injury is in hypotension, it means this is a bleeding happening somewhere else. Just so. Comes to in hypotension, it means there is somewhere else bleeding happening. So please be very, very careful about it. So you will be provided with a clinical profile of the patient and they will try to divert you towards a head injury part and you should think of somewhere. So I'll give you an example. There was a question asked already that the patient of RTA comes to you with a complaint of loss of consciousness, vomiting and seizures. On examination, found to have a pulse of 110 per minute and blood pressure 90/70. What is the most likely cause? The choices are SAH, SDH, EDH, or ARDS. What is the most likely cause? SAH. SDH, EDH, or ARDS? Abdominal bleeding. A patient of head injury cannot be in hypertension. If it is hypertension, if there is hypertension, think of bleeding happening somewhere else. Now, in a head injury, you all have seen that the problem is happening because of increased intracranial pressure. All those signs and symptoms were of increased intracranial pressure. So, our primary objective in management of a patient of head injury is to lower intracranial pressure. Right? At your level, nobody is going to ask you that what you do in this patient of EDH, what you do in this patient of SDH. You will not be asked on that. You will just be asked that what are the ways to lower intracranial pressure. So you should know there is a medical way of lowering intracranial pressure. There is a surgical way of lowering intracranial pressure. What are the various ways of lowering intracranial pressure? There is a medical means of lowering intracranial pressure. There is a surgical means of lowering intracranial pressure. The medical means of lowering intracranial pressure are 100% oxygen, 100% oxygen with initial hyperventilation, 100% oxygen with initial hyperventilation, elevating head end of the bed. When you elevate head end of the bed, then also the intracranial pressure gets lower. Maintaining or keeping normovolemia also lowers intracranial pressure. Hypertonic saline lowers intracranial pressure. Osmotic diuretics like mannitol lowers intracranial pressure. Neuromuscular blockers lower intracranial pressure. Neuromuscular blockers lower intracranial pressure. Hypothermia important. Hypothermia important. Lowers intracranial pressure. Benzodiazepines lowers intracranial pressure. Benzodiazepines lowers intracranial pressure. Barbiturates also lowers intracranial pressure. So these are the various things medically which can lower intracranial pressure. And highlight it in your notes. Steroids have no role in lowering intracranial pressure in head injury. Steroids have no role in lowering intracranial pressure in head injury. Okay, these are the medical ways of lowering intracranial pressure. What are the surgical ways? The surgical ways are craniotomy. The surgical ways are craniotomy. The surgical ways are craniotomy, burr hole, ventriculo peritoneal shuntings. Ventriculo peritoneal shunts. These are the various surgical ways of lowering intracranial pressure. Ventriculoperitoneal shunt. These are the surgical ways of lowering intracranial pressure. Right? Then, once a patient who has a head injury, a patient of head injury has a risk of developing post-traumatic seizures. A patient of head injury can develop seizures after head injury also. And it is called early seizures when they are seen within 7 days of head injury. Once you get a seizures within 7 days of head injury, it is called post-traumatic seizures early type. It is called late when it is seen any month. If it is seen many months or years after head injury. When seizures are seen after months or years after head injury, it is called late post-traumatic seizures. It is called late post-traumatic seizures. And for these post-traumatic seizures, we are supposed to give prophylaxis also. And this prophylaxis is given with phenytoin for first 7 days only. To prevent these seizures, we will give prophylaxis with phenytoin for first 7 days only. These are the things we need to know in addition to any question. We can't be sure, but if it is happening after head injury, many months or years, and there is no foci seen inside the brain, and there is a history of trauma, you can take it as it's a it can be, but then definition is this. Prophylaxis to prevent the seizures. That is that. Mechanism of seizures with medical trauma channel block. I think we could not plan. Phenytoin का एक्ट करके जरूर बताओ. Phenytoin का mechanism of action. कहाँ से? मुझे नहीं पता. हाँ? तो कुछ पूछ रहा था? सब नहीं करेगा. इसमें लेटलाइजिंग साइन है. और जॉब में वो निकालेंगे. लेटलाइजिंग साइन होगा तो निकालेंगे. अगर हम कंजर्वेटिव मैनेज कर रहे हैं तो अपने आप रिजॉल्व होगा. हमारी बॉडी में यूज होता है, रिजॉल्व हो जाता है. क्या कर चले? सोडियम चैनल सोडियम से रिलेटेड होता है, राइट? बाबा पे ब्लॉक करता है बेंजोडाइजेपिन्स, बार्बिटूरेट्स. मुझे भी याद है. Okay, now this was about headache. Then comes in neck injury. मेरी सुनने की अब फैल जाऊंगा नहीं पढ़ाऊंगा neck injury. In neck injury, we need to know what is the definition of penetrating injury neck. When do you call injury to neck a penetrating injury? Can anybody tell me?
Damage हो गई
Breach of plss. Now let's see who answered this question right. Imagine a patient comes to you with a stab injury in neck, breaching plss, and there's a profuse bleeding happening from the neck wound. There's a profuse bleeding happening from the neck wound, and the patient pulse is 140 per minute, and blood pressure is not recordable. Pulse is 140 per minute, and blood pressure is not recordable. What will be your immediate next line of management? Immediately? Apply. What will be your immediate line of management? Louder. Pressure. No pressure. Stab injury हुई, चला था पार्टी से stab. सुन लो, जिसको नेक इंजरी हुई है, उसका एयर में नहीं जा सकता. This is what I want you to engrave here. Don't jump to directly. We will apply pressure, but that will after air. Very good. Okay. Now, you have also seen that in our discussion on trauma and primary surgery, we have already applied a collar. Cervical collar. Now, if the patient doesn't have any problem in the spine, we should be removing this collar, isn't it? If the patient doesn't have any problem to the spine, we should be removing this collar. But if the patient has a problem in the spine, we should be teaching it. So, how will we decide that the patient has a problem in the spine or not? Whether we should keep this collar or not, that is decided on the basis of a criteria. You don't need to go into the detail of that criteria. You just need to know the criteria there which decides whether the collar should stay or should get removed. And that criteria is nexus criteria. That criteria is nexus criteria. In this nexus criteria, N stands for neurological deficit. N stands for a neurological deficit. E stands for ethanol intoxication, means alcohol intoxication. X stands for extreme distraction injury. U stands for unable to provide history. S stands for spinal tenderness. N stands for neurological deficit. N stands for neurological deficit. E stands for ethanol intoxication. X stands for extreme distraction injury. U stands for unable to provide history. and S stands for spinal tenderness. On the basis of this criteria, we will decide whether the patient's cervical collar should be removed or should stay, right? And for spine evaluation, for cervical spine evaluation, we should do, very important point, how will you evaluate spine? If you are told that you have to evaluate spine, whether there is an injury to the spine or not, what investigation will do? You should do CT scan of the spine. CT scan of the spine. But if CT scan is not in the choice, yeah, then we will do X-ray of the spine, AP, lateral view. And please note this point, very important. Whenever we do X-ray of the spine, we should always do it on the bedside. Whenever we are doing the X-ray of the spine, we should not be sending the patient for X-ray. We should get this X-ray done on a bedside. Very important point. We should always get the X-ray done on bedside. Okay, this was about if the patient has a neurological deficit, if the patient has ethanol intoxication, if the patient has an extreme distraction injury, if the patient can't provide history, if the patient has a spinal tenderness, you can't remove collar. बहुत हॉस्पिटल्स में बेडसाइड एक्सरे नहीं होता है. ऐसे हॉस्पिटल्स के हिसाब से गाइडलाइन नहीं बनती. हमें आंसर गाइडलाइन के अकॉर्डिंग करना होता है, राइट? अब आपसे कोई बोले कि आपको पेशेंट को widest board possible cannula लगाना है. You have to put a widest board possible cannula in trauma. आपको मेरे पास cannula है नहीं, मैं cannula मेरे यहाँ मिलती नहीं. कोई ऑप्शन नहीं. फिर कॉलर लग रहा है तो चलने तो काम जब तक एक्सरे नहीं आ रहा. क्या करो? ऐसी जगह के लिए कोई कानून नहीं कर सकते, है ना? Our question is, even if the patient can move, we will still do a bedside X-ray. A cervical spine injury patient, where you are suspecting a cervical spine injury, you think will be moving? चला जिस हॉस्पिटल में एक्सरे नहीं हो रहा है बेड साइड, उसमें सी आर्म की बातें हो रही है. So this was about a neck injury. Then comes thorax. That's where the mood is. Ten o'clock. Yes, sir. I want to be sure. Most common thoracic injury. What is the most common thoracic injury? Most common thoracic injury is rib fracture. Which rib is more commonly fractured? Most commonly fractured ribs are 4th to 9th rib. Most commonly fractured ribs are 4th to 9th rib. Then, can you tell me what is the most common cause of sudden? This sudden word is important. sudden death in blunt thoracic trauma. Most common cause of sudden death in blunt thoracic trauma, a very commonly asked question, it is aortic injury, followed by tracheobronchial injury. Most common cause of sudden death in blunt thoracic trauma, aortic injury followed by most common cause of sudden death in a penetrating thoracic trauma is cardiac rupture followed by aortic injury. Followed by aortic injury. Now, then comes a very, very important thing in thoracic injury, which they very commonly asked also. There is something called plain chest, which is also called stove in chest, which is also called stove in chest. Can anyone tell me what is the speed fine?
Yes,
All of you? Stove in chest. What is plain chest or stove in chest?
the plain part of the plain is opposite during the respiration.
Two or more fracture of two. This two is important. Fracture of two or more consecutive ribs at more than 1 point in one line. Fracture of two or more, two, it is not three. Answer in your MCQ source is wrong. Two or more consecutive ribs at more than 1 point in one line. इसका मतलब क्या हो? Let's understand the meaning. Imagine this is the thorax. Imagine this is thorax. Will this lead to flail chest? Tell me. Will this lead to flail chest? No? No? Will this lead to flail chest? More consecutive ribs. This is something important, right? Now, once two or more consecutive ribs fracture at more than 1 point, then it becomes a flail chest. And now you can see this segment of the rib got detached from the normal thoracic cage. And this segment is now called flail segment. This segment is now called flail segment. And this segment, which is flail segment, now going to move paradoxically. So this segment is now going to move paradoxically. So there will be paradoxical respiration going to happen in this segment. What does that mean? On inspiration, this segment will go down, which you are saying also. In this this segment will dip down on inspiration. On expiration, this segment will come out. On inspiration, this particular segment, normally the ribs gets elevated on inspiration, falls on expiration. This segment on inspiration will dip down instead of elevating, and on expiration it will elevate. So it will move paradoxically to normal. So since it is moving paradoxical to normal, this is called paradoxical respiration 1. And since this segment is moving paradoxical to the normal rib segment, so you can easily make out one particular part of the thoracic wall is moving opposite to the normal. So since you can see it easily on your clinical examination, you can make a diagnosis of flail chest clinically also. So diagnosis of flail chest can be made a question asked on clinical examination. However, if you want to confirm this diagnosis, the investigation of choice for this is chest X-ray. Investigation of choice for this is chest X-ray. And this, remember, as a rule, answer in your MCQ source again has a problem. In any patient with flail chest, whatever the condition of the patient may be, please appreciate one point here. If this segment is moving like this, imagine this is a flail segment and it is moving paradoxically. So this segment on inspiration is going down. So since it is going down, it will injure the lung also. Agreed? Agreed? So every flail chest, underneath that segment of flail segment, there is always a confused lung there. Because the lung is all the time is getting hit by the ribs. Are you understanding? So every flail chest, underneath that flail chest segment, there will be a confused lung. Always. Right? Your lung, normal thoracic wall moves like this. When the lung is expanding, the thorax is going up. When the lung is collapsing, the thorax is coming down. Right? So at any point of time, the lung is not hitting the thorax, not hitting. But what is happening in flail chest? This is happening. So in inspiration, this flail segment, imagine this is a flail segment, it is dipping down. So the lung is expanding, elevating, but the thoracic wall is going down. So it will hit this lung every time, so it will injure this lung. So when it injures this lung, it will lead to confusion of the lung. So every flail chest, underneath it, there will be a pulmonary contusion. So in every flail chest, there is a pulmonary contusion under it. One thing one should know first. And in any flail chest, whatever the condition of the patient may be, the first line of management always is oxygen with pain control. Oxygen with pain control. The best way, very commonly asked question, the best way to achieve pain control, in flail chest, very commonly checked question, is epidural analgesia. Best way to achieve pain control in a flail chest is epidural analgesia. If not there in your choice, then it is intercostal nerve block. Then it is intercostal nerve block. Right? But after this, you have started oxygen, you have started a pain control, but after doing this, if the oxygen saturation of the patient is less than 85% provided to you in any given question, even after oxygen therapy and pain control, if the oxygen saturation of the patient stays below 85%, we are supposed to go to the next level of our management, which is a treatment of choice, very good, which is a treatment of choice for clear chest also, and that is intermittent positive pressure ventilation, which is intermittent positive pressure ventilation, which is intermittent positive pressure ventilation, intermittent positive pressure ventilation. So you can appreciate from here, if you are asked what is the treatment of choice for plain chest, your answer will be IPPV. But you should understand in a clinical approach to a patient, we will never go to IPPV without starting a 100% oxygen with IPPV. Now, strapping of the ribs. Please note, strapping of the ribs is absolutely contraindicated in clear chest. Strapping का मतलब क्या होता है? Applying adhesive from sternum to vertebra. Applying adhesive from sternum to vertebra is strapping, and this is absolutely contraindicated in future. One should never do strapping of the ribs, and this will be a question also in exam. Okay, so this was about flail chest. Then comes aortic injury. If there is a ये अपने आप स्लिप जुड़ेंगे ऐसे हाँ. The question is, sir, रिब टूट गए, हमने तो पेशेंट को आईपीपीवी कर दिया, तो अभी जुड़ेंगे कैसे? What you do when the femur gets fractured? You apply a cast. You apply a cast. You apply a cast. What the cast does? It keeps the two segments of the bone in one hand. It does this one and the canal step form. ये होता है ऑटोमेटिक हो गया. What is IPPV? Intermittent positive pressure ventilation. What is happening is, imagine this, my right hand is a fluid segment. It is moving like this, right? What IPPV does, intermittently, positive pressure ventilation I am going to provide. Means, with the synchronizing with the respiration of the patient. Patient is doing inspiration and expiration, and this is happening. Agree? So what I am going to do, during the inspiratory phase of this patient's respiration, I will give a positive bolus of ventilation, means air. So when I give a positive bolus of air, this segment of the rib was dipping down. So what will happen? This will get lifted, right? And during expiration, I will not do anything, so it will fall back. Again, during inspiration, I will do this. So this segment will get lifted with the original rib, the normal ribs. So at any point of time, now, the ribs are moving in one line. So this is kind of a splint of the ribs you have done, like the cast does for a limb. So this way the ribs are moving also, but at the same time in one line also. This is called pneumatic splinting. And this way the callus will be formed. Huh? Patient, see, movement patient can maintain his oxygen saturation. Patient will be out of this IPP. Okay? No? Pneumatic splinting. Then comes aortic injury. You all have seen that most common cause of sudden death in blunt thoracic trauma was aortic injury. बर्तन गिरने लगा. In blunt thoracic trauma is aortic injury. The second common cause of sudden death in penetrating thoracic trauma is aortic injury. So that means most of the patients of aortic injuries are dying on the spot. Most of the patient of aortic injury, that means, dies on the spot. There are very few lucky ones will reach to the emergency services. Who will reach to the emergency services? Only those patients of aortic injury will reach to emergency services in those who have the intact adventitia. The injury happened in such a way to the aorta that intima and media of the aorta got injured, but adventitia is still intact. Adventitial layer is still not injured. Tunica and media got injured, but adventitia is still not injured. Only such patient of aortic injury can reach emergency room. And it is like a time bomb now, ticking time bomb. Anytime this adventitia, because there is a very high pressure in the aorta, so anytime this adventitia will give way and the patient will have a torrential bleeding, right? So these patients who are going to reach to the emergency room, they need to be investigated immediately. They need to be suspected immediately, because if you don't suspect them, if you don't investigate them, you can lose them in any time. So you have to be suspicious. When will that this kind of thing will happen? And once you are suspicious, then only you can proceed about investigating about the aortic. So when should we suspect? This is an important point. There will be a clinical profile to the, in a given question provided to you, and you will be asked that what will you do in this given situation. In any patient of thoracic injury, please listen to this carefully. If you are provided that there is a widening of mediastinum, if you are provided that the mediastinum is widened, right, or you are provided that the patient has a fracture of first, second rib or scapula, in any such patients, we should always suspect aortic injury. And where are you seeing this? Where are you seeing this? X-ray chest. And when are we doing this X-ray chest? In every patient with primary survey. In primary survey, we did 2 X-rays. So that is why we always do chest X-ray in any patient of trauma. So in any patient of trauma, if you find a widened mediastinum on chest X-ray or fracture of first, second sternum or scapula, this is a very important clinical clue in a given question in your exam to think about a aortic. And whenever you find this, you have to do CT angio. So the investigation of choice for aortic injury is CT angiography. So any such patient, if comes to you, you have to do a CT angiography. So trauma questions, as I said already, are going to be very tricky. We have to pick those key points in the questions, and then only we can diagnose those problems and manage those problems also. So trauma questions are going to be very complex in a way if you don't know the concept, but they are going to be very simple if you understand the concept. And please, this is my sincere request to you. We have done breast. We will be finishing off the trauma, majority of the trauma today. Please go back home and do the questions. So you may be understanding at this time, you may be writing also things here, and you are understanding, you feel that you are understanding things. This whole exercise is of no value if you don't reciprocate it in MCQs. right? So if you can't do solve MCQs after this class, this whole class is of no use. See to it that whether you can solve the questions or not. And I want to know that feedback. And this is my assurance to you that these notes will be one-stop solution for your exam. But then you have to know how to apply. Like I gave you a very simple formula for making out the stage of a carcinoma breast. If you don't know how to apply it, that formula is absolutely waste. So please, this is my sincere request to you that do questions and let me know. Tomorrow we will not have a class. Tomorrow there is no surgery class because we have already some class planned. We will have a class on Saturday. So I want to hear from you that whether you will solve the questions or not. Okay? Okay, and the most common site of aortic injury is just distal to the origin of left subclavian artery or ligamentum arteriosum. Most common site of aortic injury is just distal to the origin of the left subclavian artery or ligamentum arteriosum. And the treatment of choice of aortic injury is endovascular stenting. Treatment of choice for aortic injury is endovascular stenting. Right? Then comes indications of emergency thoracotomy in thoracic trauma. Indications of emergency thoracotomy. When will you do it? See, okay. You all know what is ectomy. Removing something. When I was at your level, I had that gross confusion about otomy and ostomy. So let us clear this concept so that whenever the statement comes in our surgery discussion, we could make out what is happening. So can you tell me what is otomy and what is ostomy? What is the difference between stomy is opening and otomy? What? In what? In otomy. Very good, very good. So you are very good. You are better than what I was at your level. I didn't know that. Thank you. Okay. Now, what is otomy and what is ostomy? Just for your, since you know it, but still I want you to be very clear about it. Otomy as a suffix can be applied to a hollow thing, can be applied to a solid thing, right? Whenever it is applied to a hollow thing, it means opening that hollow thing, and for whatever reason you have opened it, closing it down. Laparotomy, opening abdomen, for whatever reason you have opened it, close it down. So it will be otomy. Thoracotomy, opening thorax and then closing it back. Otomy as a suffix can also be applied to a solid thing. Myotomy, muscle, is a solid thing. So if a otomy as a suffix is applied to a solid thing, it means dividing that solid thing. Just cutting that solid thing. Myotomy means cutting that muscle. Right? Now, ostomy as a suffix When applied, it means opening something and leaving it open. So if I open abdomen, say for example, on this simple thing, there is a question in AIMS examination. If I open abdomen and if I don't close it, what will it be called? Laparoscopy. Laparoscopy. When I open abdomen, I close it, it will be laparotomy. When I open abdomen, I don't close it, it will be laparoscopy. Colostomy, making an opening in colon on the surface of the skin and leaving it open. Ileostomy, making an opening in ileum on the surface of the skin and leaving it open. Gastrojejunostomy, making an opening between stomach and jejunum and leaving it open. So, thoracotomy, opening thorax, closing it. Craniotomy, opening cranium, whatever reason you have opened it. Understood? So, thoracotomy. What are the indications of thoracotomy? Now, please note one point. 80% of the time, we manage thoracic injuries just by putting chest tube. 80% of the time, chest tube is a sufficient treatment for most of the thoracic injuries. But there are times when we have to do thoracotomy also. So what are the indications of thoracotomy? We should know. The indications of thoracotomy are: 1. Indication of thoracotomy are: 1. When on putting in a chest tube, more than 1500 ml blood comes out stab. आपने जैसे ही chest tube डाला, the moment you put in a chest tube, more than 1500 ml blood comes out. You can't manage this patient without opening thorax. You have to open thorax to control bleeding. Right? After controlling bleeding, you will close it. Second, more than 200 ml output from a chest tube per hour for 3 consecutive hours. More than 200 ml output of blood coming from a chest tube for 3 consecutive hours. Then also you have to open thorax. So, esophageal injury. Esophageal injury. 4. Cardiac tamponade. Cardiac tamponade. We'll be talking about cardiac tamponade. Fifth, persistent collapse of lung even after positive pressure ventilation. Persistent collapse of lung even after positive pressure ventilation. These are the specific indications of opening thorax. Right? If any of these are there in any given question in your exam, you should know that you have to open thorax. Okay, then one important point, cardiac tamponade. How will we know what is cardiac tamponade?
Sir,
Of fluid in trauma, it is blood. Sudden accumulation of blood in pericardium. Sudden accumulation of blood in pericardium is cardiac tamponade. Now, how will a patient of we are talking about trauma, na? Right? हम तो trauma की बातें करेंगे. So, sudden accumulation of blood in pericardium in trauma is cardiac tamponade. Now, how will we know clinically that the patient has a cardiac tamponade? There is a triad called Beck's triad. Any patient, if has a Beck's triad, it means patient has a cardiac tamponade. So, what are the features of Beck's triad? Very commonly asked: hypotension, raised JVP, muffled or muffled heart sound or silent heart. If this is there, the immediate next step is pericardiocentesis. What is pericardiocentesis? Aspirating blood from pericardium. Aspirating blood from pericardium. To aspirate blood from pericardium, where will you put a needle? Where you put a needle? How will you enter pericardium? From where you will enter pericardium? यहाँ से तो जाएंगे कहाँ से? Just you will enter needle just below the ZP sternum. A question asked. You should enter needle just below the ZP sternum, directed towards left shoulder. You should enter the needle just below the ZP sternum, directed towards left shoulder. ZP sternum. After this is the immediate step, but the definitive treatment is pericardiotomy. What is pericardiotomy? Opening of the pericardium, evacuating blood, and then closing it back. So this is how we will make out that it's a cardiac tamponade. So these are some of the important points we need to know. Now, very important question. Let me ask you. If you can recall, hypotension and raised JVP. Hypotension and raised JVP was there in tension pneumothorax also. Hypotension and raised JVP is here also. So, how will you know in a given question the patient has a tension pneumothorax? Examiner ने दो ही finding दिया आपको. Examiner ने आपको बोला, examiner told you that the patient has a thoracic injury, falling thoracic injury. Patient has a hypotension and the neck veins are prominent. On what lines you will manage? Will you do a pericardiocentesis or will put a needle in the fifth intercostal space?
Sir, most of the
This is a very important point. I'll tell you, this is something then only you will understand. You know, when you're in India, in your third semester, your clinical posting starts. आपकी थर्ड सेमेस्टर में क्लिनिकल पोस्टिंग शुरू हो जाती है और क्लिनिकल पोस्टिंग में आपके बैचेस बन जाते हैं. इन क्लिनिकल पोस्टिंग्स your whole class will be divided into batches. 10 का 8 का depending on the strength of the class, your batches are done and you start going to the clinical posting. तो हमारा भी बैच बन गया. और जब आपकी क्लिनिकल पोस्टिंग शुरू होती है तो आपको बड़ा एक्साइटमेंट होती है कि डॉक्टर डॉक्टर खेलेंगे। तो हम भी बड़े एक्साइटेड थे कि डॉक्टर डॉक्टर खेलेंगे। गए, मेडिसिन की पोस्टिंग थी, बड़ा मजा आ रहा था। हर बैच में एक ना एक आइटम जरूर होता है। हमारे बैच में भी था। हमारे वो वैसे बात जो हाथ खड़े कर करके क्वेश्चन का आंसर देने वाले हमारे बैच में भी था। तो क्लिनिकल पोस्टिंग को अभी हमारे 10-12 दिन ही हुए थे, मेडिसिन की पोस्टिंग, और उसने बोलना शुरू कर दिया। इस पेशेंट में ओपनिंग स्नैप आ रही है, इस पेशेंट में पैन सिस्टोलिक मर्मर आ रहा है, यहाँ पे लगभग समझ नहीं आ रहा। वो पता नहीं कौन कौन सी आवाजें बताता था जिनके नाम भी नहीं सुने करता अब तक कौन। और सबसे ज्यादा डिप्रेशन तब होता था, बैच की सारी लड़कियां हिमांशु कहाँ पे बताओ बताओ। और आपके बैच में एक अच्छी चीज ये भी होती है, तुम्हारे साथ भी होता होगा कि आपके जैसा भी कोई होता है। तो हम दोनों ऐसे हाथ फोल्ड करके ऐसे देखते रहते थे और ये टॉर्चर झेलते थे। तो कुछ दिन कोई टॉर्चर झेला हमने, फिर हमने डिसाइड कर लिया बॉस ऐसे नहीं चलेगा। हमने डिसाइड किया कि बहुत हो गया, एनफ इज एनफ। हमने डिसाइड किया कि अब हम आएंगे ही। आना बंद कर। अब 9 to 12 का हमारा पोस्टिंग का टाइम होता था, और तब हमें रियलाइज हुआ कि 9 to 12 का एक ऐसा टाइम है जब आपको कोई नहीं मिलता, आप भटक रहे हो और सब तो अपना अपना काम में बिजी है, आप ही फ्री घूम रहे हो। तो कुछ दिन तो ये चलता रहा कि यार नहीं जा रहे, फिर थोड़ी दिन बाद लगा कि यार पास तो हमें भी होना है, एग्जाम तो हमें भी देना है, जाते हैं कुछ करेंगे। तो गए, दोबारा से वही कहानी शुरू, इसमें ये इसमें वो। मैं कहा यार ये तो ज्यादा है। अब ऐसे में फिर क्या करो, सीनियर से जाकर बात करके सर, धीरे से गए, धीरे से डर डर के सीनियर से बोला सर वहां वो पता नहीं क्या क्या आवाजें सुना रहा है, आप हमें बस ना हमारी छोटी छोटी खुशियां हमें लगभग बता दो कैसे। वो मम्मल और ये फैंसी स्टोरी वो सब बाद में देख लेंगे, हम अपने लगभग पहचानना सिखा दो। उसने कहा कौन सा पेशेंट है, मैंने सर वो बेड नंबर 9 पे पता नहीं कौन सी मरमर बोल रहा है वो। चलो गए, हाँ हिमांशु कौन सा मरमर आ रहा है, सर मिड डायस्टोलिक मरमर आ रहा है। इतना कॉन्फिडेंटली सीनियर से भी बात करता है यार, ये कहाँ आ रहा है, तो सर माइट्रल एरिया पे। माइट्रल एरिया ऐसा कोई एरिया था? हम तो कहीं भी रख रहे। This muffled heart sound is such a delicate thing. Leave alone for trauma scenario. In any scenario, listening to muffled heart sound is a very difficult proposition. In trauma, where there is so much of commotion going on around, this muffled heart sound or silent heart is very difficult to appreciate. So, in any given question in exam, if hypotension or raised ABP is provided, you should always manage it on the lines of cardiac pericope. Unless you are provided with the status of breath sounds. Otherwise, once hypotension and raised ABP is there, it is cardiac. Understood? Yes. So this is something which you should always keep it in mind. Now, before you call it a day, let me tell you one very important point here. Next time, whenever Saturday we'll be meeting, so we will be talking about abdominal trauma there. But before we talk about abdominal trauma, just one thing I want you to know here. Can you tell me what is abdomen? What is abdomen? इंस्पिरेशन में तो नीचे, एक्सपिरेशन में ऊपर। देखो ये बहुत इंपॉर्टेंट बात बोलने जा रहा हूँ। I'm going to talk about a very important thing here. Abdomen extends from fifth intercostal space bilaterally to inguinal face. So even if, please be very, very vigilant in your clinical profile of a patient. If any patient has an injury below fifth intercostal space, even though it's a primarily a thoracic injury, you should always think of abdominal trauma along with it. So say for example, you are told patient has a 6th, 7th, 8th, 9th rib fracture on left side. It's a thoracic injury, but then since it's a 5th intercostal space below, you have to think about the abdomen also. And once such injury happens, the most common organ which get injured on left side is spleen. Most common organ injured on right side is liver. So please, whenever such profile of the patient comes in your clinical question, always think of the abdominal trauma there. So with this, we call it a day, but with this promise from your side that you will be doing the questions and you will tell me your feedback also.